Medical Tourism Corporation interview with Dr. and Professor K.N. Krishna, neurosurgeon, brain and spine. Dr. Krishna has several research publications and presentations. He also has extensive surgical experience.
Well, my name is Dr. K.N. Krishna. I have done my basic medical course in India, as well as super specialty in surgery and neurosurgery. That was about 2 decades ago. And then I've trained in various parts of the world, like Germany and Japan, for my further training in microsurgery and minimal access spine surgery. I've been heading medical colleges, in medical colleges, the neurosurgery department, where training of the residents were involved, and have a special interest over here in spinal surgery. Essentially, I've been doing surgery from basically craniovertebral junction up to the lumbosacral junction, congenital to trauma, and what especially interests us is the degenerative spondylosis, both cervical and lumbar. And of late, there are more and more armamentarium available to us in terms of decompressing the spinal cord, as well as keeping the spinal segment mobile. And that's what we call now dynamic stabilization. For instance, in the last couple of years, we have been doing the FDA-approved cervical and lumbar arthroplasties. Apart from both anterior and posterior fusions with stabilization, instrumented stabilizations in both cervical and lumbar region. And in addition, we have gained expertise in minimal access techniques in spinal surgery and spinal instrumentation, which is being carried out on a routine basis here. We have also adapted fluoroscopic guided and neuronavigation for spinal instrumentation, and I think over 500 spinal surgeries are done in this hospital in the last 18 months, which include all the range from the congenital anomalies to degenerative diseases and the trauma. We have also been very adept at using disc preserving surgeries, wherein we do microforaminotomies, both cervical as well as the lumbar. We have here used both Brion and the Prestige, the next version from the Medtronics, on a routine basis. We have done about, when we have gone up to 3 levels, because basically what we feel is, technically it is very simple. What works for one level should work for the second level as well as for the third level. Whereas fusion surgery is being approved over years by FDA and world over, wherever instability has been in question after we do a decompression. So what could go wrong if you have a 3-level replacement? That's how our thinking is. Worst would be whether we will not get a total dynamic spine. It might become a immobile segment or a costly fusion at one level, but however there is no proof that it will not work. It's been only, I think we feel it's only a stepwise approval by the FDA. So our patients are comfortable with replacement because the technique remains same. You have a single scar and you do replace it at multi-level. There are certain indications where you wouldn't like to go and replace the disc. If there is too much of osteophyte formation and if there is too much of swan neck deformity, as it happens in many elderly spondylotics, there we would prefer to still use a fusion as a technique. Third thing also we do is something called modified Joe's technique. and also posterior foraminotomy for disc. Sometimes we do find young individuals with a small, fresh, soft disc coming out only to the foramen. These are the surgeries or minimal access surgeries which are done for the local people almost to the daycare. We keep them for 48 hours because we do under general anesthesia at present, and their disc is preserved. We take care of only a small foraminotomy or a transcorporeal hole through which Professor Joe first described, wherein only the extruded disc is removed. So patient is retaining his natural material. So on a case-to-case basis, we extend the range of surgery from disc preserving surgery to disc arthroplasty. I think disc arthroplasty is here to stay, and as we do more cases, more development may come in. At present, we have up to 48 months, 24 months follow-up with this pair with Prestige disc replacement from Medtronics, which is available. And we have also used in the lumbar region Marvic, again by Medtronics, both anterior and anterior oblique replacements. And in fact, right now one of my colleagues is doing today 2-level lumbar replacement. See, some of the European countries as well as in Hong Kong and in Singapore, these regions where there's not too much restrictions, just like us, more than 1-level replacements have been carried out. Overall patient satisfaction rate in terms of axial pain and the long-term follow-up have been very good. Compared to the fusion group, or we do have the axial neck pain and radicular pain improvement, which is statistically significant. I think they're all well out and publications as late as 2008 March spine. In fact, yesterday I came across the article for the question you asked, and what we heard it in August is being on print now, the cervical disc replacement. Because the lumbar disc replacement still is being done, and those patients who are keen to have a mobile segment, and those of us who believe that it should give us a chance. Also other dynamic stabilizations like using the interspinous spacers are also being tried.
Medical Tourism Corporation facilitates affordable medical treatment at world-class international hospitals. Fill out the estimate request form on our site for a free quote and more information.